Welcome to part 5 of this chapter summary, chapter 19, Cardiac Catheterization of BRAUNWALD'S latest edition by Charles Clinton. We'll be talking about the clinical aspects and integration into patient care, mainly valvular stenosis, valvular regurgitation, and shunt determinants. Sorry, we already talked about stenosis in the previous section. We're talking about regurgitation and shunt determinants. So, this is in general in the cath lab, regurgitation severity is done visually. If in doubt or if you need more objective values, you can calculate regurgitant volume, and with this, you can check out the regurgitant fraction. After this, it is recommended that you correlate your visual grading of the regurgitation with the regurgitant fraction. We will see how to do this in a minute. Remember, it is a class 1 ACC, American Heart, recommendation to do hemodynamic evaluation of aortic or mitral regurgitation when the pulmonary artery pressure is disproportionate to the regurgitation severity or inconsistent with the findings. So in the illustration A above, you can see in the first line a RAW representation, and in the second line a LAO representation in the angiography lab. RAW right anterior oblique and LAO left anterior oblique. With this, you can see a ventriculogram, and remember that the valve you want to evaluate, you should inject contrast right after it. So in illustration A, it's normal. Illustration B is showing you a drawing format where there's different grades of mitral regurgitation. How can you grade this visually? Here you have the grading system. It's 1 cross to 4 crosses. You can pause the video and see how this is graded. But in general, you'll take into account how much opacification is seen, and you'll also take into account when the clearing of this opacification is given. The faster the clearing, the less the opacification, probably a grade 1 cross. The lesser, the opposite, probably grade 4. And there you have the shades of gray to compare it. As a more quantitative measure, we talked about regurgitant volume. How can you calculate this? Well, you will subtract angiographic stroke volume minus forward stroke volume. The angiographic stroke volume is calculated by using the left ventriculogram. You'll get the end-diastolic volume and systolic volume, and you'll check the stroke volume. With this stroke volume, you will know, you'll get the stroke volume. And then the forward stroke volume is calculated by the Fick equation or by thermodilution, whichever you use. There are some prerequisites for correct measurements, which are steady state physiology. Hopefully, what are we thinking about? Similar heart rates, stable hemodynamic status, and a single regurgitant valve. So that's for the regurgitant stroke volume. Now, how can we get the regurgitant fraction? It is pretty simple. We already have the variables. You have to do the regurgitant stroke volume and divide this by the angiographic stroke volume. This will give you a fraction. And after you have this fraction, go and correlate it with your visual grading. In general, 1 cross is 20% or less regurgitant fraction. 2 crosses correlate to a regurgitant fraction of 21 to 40%. 3 crosses to 40 to 60%, and 4 crosses more than 60%. Now let's talk about shunt determinations. Look at the drawing here. On the right, looking at the patient in his anatomic stance right in front of you, on the right you have deoxygenated blood. Everything that's coming up the vena cava into the right heart has to have low oxygenation. It's deoxygenated. On the left side of the heart, you have oxygenated blood, and this is because it already passed through the pulmonary circuit, and there was the hematogenous exchange. So when you have shunts, a shunt is when there's an alteration in the pulmonary or the systemic flow. Remember that pulmonary and systemic flows are in circuit. It's like a choo-choo train. The choo-choo train passes first through the lungs and then comes into the heart and then goes out the heart to the systemic system. It's set up in series, so that everything that comes in the pulmonary system should go out through the systemic system, so the output should be the same. If this does not happen, we're talking about a shunt, which can be left to right, meaning oxygenated blood going to the right side, to the deoxygenated side, or right to left, where deoxygenated goes to the oxygenated side, or bidirectional. There are different methods of measuring this with dyes, which are pretty accurate and can detect very small shunts. The thing is that the dyes won't tell you where the shunt level is at. Another one is with oxygen content. It's pretty good, but it won't tell you exactly where the shunt is at. And to detect this, you will need time for each measurement, 15 to 30 minutes approximately. And the O2 saturation is the fastest of these methods. It detects significant shunts, is pretty accurate, is pretty fast, and helps you localize where the shunt is at. Here you can see the different saturations at different parts of the system. So look at superior vena cava has less saturation than inferior vena cava when you are sitting down, where you are not doing exertion. Why is this? Because your brain is much more active than your relaxing muscles, and it is consuming much more oxygen. This translates into a lower saturation. Then look at the other saturations in the graph. There is no jump, significant jump. All have a difference of less than 5%. So when we do a full saturation run, this means that we'll check out the saturation at different points. A full saturation run is talking about checking out the inferior vena cava, superior vena cava, right atrium, right ventricular inflow, mid cavity, right ventricular outflow, main pulmonary artery, left or right pulmonary, and left atrium. And if you can, left ventricle and distal aorta. That is a full saturation run. How can we suspect shunts in a large or macroscopic manner? Left to right shunt. If you got a pulmonary artery saturation which is more than 80%, something is happening. Why? Because the pulmonary artery should be pretty deoxygenated. Why do we have a saturation more than 80%? Is this a left to right shunt? Maybe. Go check it out. Or a difference of 8% between superior vena cava and the pulmonary artery is also makes you suspect of left to right shunt. Why? Because there could be an interatrial communication or different communications. That's why it is recommended to check out the right atrium saturation at higher level, mid-level, low level. You have to see where this change is occurring. Or we have significant step up. What does this mean? It means a change of 5% or more of saturation. This is a significant step up, and this means you are receiving oxygenated blood from the left side. Or when to suspect the right to left intracardiac shunt. This means that deoxygenated is going to the left oxygenated side. What does this mean? That by mixing deoxygenated with oxygenated, you're lowering saturation. Then any patient with cyanosis or arterial systemic desaturation less or equal to 93%, even if you ask this patient to inspire profoundly, to inhale profoundly several times in the supine position and the patient still is desaturated, we could be talking about different causes of this desaturation. Could it be COPD? Could this patient have a pulmonary disease, a congenital heart defect, mainly left to right shunt? Sorry, this is right to left shunting. Okay, then this is where you would suspect this pathology. These guidelines for optimum utilization of oximetric method were given in 1980, but are pretty good basic knowledge. You have to take blood samples at multiple sites. You have to use oxygen saturation instead of oxygen content. Compare mean values because you have to get several different measurements. Use the mean, and because of the different alterations you could get in these cardiovascular hemodynamics, you want a steady state in that moment. How can you do shunt quantifications? Remember that you have to compare pulmonary blood flow to systemic blood flow. Then this is given by simply oxygen consumption over or divided by the difference in oxygen content across the pulmonary or systemic bed. That's how you get PBF, which is pulmonary, and SBF, which is systemic. And how do you get EBF? EBF is effective blood flow. Effective blood flow is using the pulmonary venous oxygen concentration and the mixed venous oxygen concentration. The EBF is important because you will use the EBF in order to determine if there's a bidirectional shunt. Then let's go from top to bottom. How do you get the mixed venous oxygen consumption? You can get this through the FLAM formula, which is shown there. Then how do you determine left to right shunt size? You have to, if you have left to right shunt, it means that blood from the left side is going to the right. Then which system will have a larger output? The right side. That is why you have to do PBF, pulmonary blood flow, minus SBF. That's the logic of this. And the difference between them will tell you how much is shunting. Then if you want to see if there's a bidirectional shunt, do PBF minus EBF. And if you want to know the size of the right to left shunt, do SBF, systemic, minus EBF. And wrapping up, what are we talking about? We're talking about the QP to QS. Q equals flow. This means a pulmonary flow over systemic flow. What does this mean? It's a fraction. When you do this in a fraction form, as you can see in that line, PBF over SBF ratio, it is counterintuitive because the systemic arterial oxygen concentration minus the mixed venous oxygen concentration is talking about systemic. Then why is this mixed up? Is this an error? No, it is not an error. When you do all this formula and when you cancel all things out, remember there's one formula, there's one ratio over and not dividing itself by another ratio. When you combine all variables, the systemic oxygen consumption ends up above the pulmonary oxygen consumption. Pause the video and do this manually or look up the whole calculation formula and you'll see that it makes sense. So if you have a PBF or QP over QS, which is more, or it should be 1, output should be 1. If it's more than 1, it means that the QP is more than the QS. It means that there's a left to right shunt. It's a small left to right shunt. If the QP to QS is 1.5 to 2, it's moderate. And if it's more than 2, it's a large left to right shunt. What happens if it's less than 1? You have a right to left shunt. Why? Because systemic flow is larger, which means that flow from the right is bypassing the lungs going on to the left. And that's it for this recording. Thank you.